In 2023, the American Medical Association found improper coding of therapeutic injections drove over $500 million in denied claims, mostly from preventable documentation errors. The risk is not the code. It is the documentation gaps and modifier rules most teams do not check. CPT 96372, therapeutic, prophylactic or diagnostic injection, subcutaneous or intramuscular. Here is the complete guide for billers and practice administrators. We cover the code definition, the 5 documentation requirements, reimbursement rates, modifier rules, and compliance exposure. CMS defines 96372 as subcutaneous or intramuscular injection administration, not the medication itself. The code covers the administration service. The drug is billed separately under its own code, never bundled. IV injections and vaccines use different code series. Using 96372 for either is an automatic denial. The AMA found improper coding of therapeutic injections resulted in over $500 million in denied claims in 2023. That figure represents preventable errors, wrong codes, missing modifiers, incomplete documentation. Your team can stop. Beyond denials, billing errors can trigger payer audits, False Claims Act exposure, and exclusion from federal programs. Payers require 5 elements before they reimburse 96372. Miss any one and you face a denial or audit exposure. Let us walk through all 5. The injection must be subcutaneous or intramuscular. If the route is intravenous, 96372 does not apply. The route of administration must be explicitly recorded. Payers will check for it. Document the medication in full. Record medication name, dosage, route, and injection site in the chart. The drug gets its own separate code on the same claim, never bundled. The injection must be administered by a qualified healthcare professional. The administering provider must be a physician, nurse practitioner, or physician assistant. The chart must record that a qualified provider administered the injection. The medical necessity of the injection must be clearly stated. The patient record must state why the injection is medically necessary for the condition being treated. Necessity language must explicitly connect the injection to the diagnosis being treated. Document any immediate post-injection monitoring. 96372 accounts for the time to prepare, administer, and monitor after the injection. Gaps in the clinical record expose the claim to denial or reversal. 2 modifier rules are where most 96372 claims break down. For multiple same-day injections, use 96372 for the first, and append modifier 59 to each subsequent injection. When billing an EM service the same day, append modifier 25 to the EM code, not to 96372. Rates vary by payer, geography, and contract. Verify current rates before relying on them. Medicare typically reimburses $25 to $35 per injection, depending on geography. Verify via the CMS physician fee schedule. Medicaid rates range from $15 to $40. Check your state fee schedule. Private insurers typically pay $30 to $50 based on negotiated contract terms. The most common 96372 denial reasons are all preventable. Using 96372 for an IV injection or vaccine is a hard denial. Confirm route before coding. Append modifier 59 to each additional same-day injection so each bills as distinct. Append modifier 25 to a same-day EMM code so it bills as a separately identifiable service. Missing drug name, dosage, or injection site gives auditors grounds to reverse payment. BehaveHealth.com connects clinical documentation to billing, so the elements that make a 96372 claim defensible are captured at the point of care. The EHR is designed to prompt clinicians to document medication name, dosage, route, and injection site at the point of care. The RCN layer is designed to surface missing modifiers before claims go out. Stop losing revenue to denied 96372 claims. Book a 20-minute demo at BehaveHealth.com. See the EHR and RCM billing workflow built for behavioral health providers at BehaveHealth.com.